Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Neisseria gonorrhoea. Neisseria gonorrhoea is a sexually transmitted infection, although it can also have mother-to-child transmission at delivery. The prevalence is highest in South and Southeast Asia, as well as Sub-Saharan Africa, and overall the highest incidence rates are amongst adolescents and young adults, particularly those aged 15 to 24. Neisseria gonorrhoea is a gram-negative, oxidase-positive diplococcal bacterium. It evades the immune system through antigenic variation of pili and outer membrane proteins. It adheres to and penetrates epithelial cells of mucous membranes, leading to inflammation and purulent discharge. The clinical manifestations can be quite variable. The most common and frequently spoken of is the urogenital manifestations, which include dysuria and purulent discharge from the penis or the vagina. It can also lead to pelvic inflammatory disease, or PID, in women, resulting in chronic pain and even infertility. Disseminated Neisseria gonorrhoeal infection can lead to skin lesions, arthralgia, and septic arthritis, particularly in individuals with compromised immune systems. More rarely, Neisseria gonorrhoea can cause a perihepatitis picture, also known as Fitzhugh-Curtis syndrome. Diagnosis is made through culture of bacteria from symptomatic areas, specifically using the nucleic acid amplification test, or NAT. This is the gold standard due to its high sensitivity and specificity. Management is usually with dual therapy of ceftriaxone and azithromycin to cover potential co-infection with chlamydia trachomatis and mitigate resistance. The emphasis is on testing for and simultaneously treating other STDs. Antibiotic resistance patterns vary regionally and is a worldwide problem. Prevention is key for this condition, and there is recommended regular screening for sexually active individuals under 25, as well as pregnant women and high-risk populations. Contact tracing is critical for controlling the spread and involves notifying and testing all recent sexual partners of infected individuals. So now let's try a question. A 23-year-old male presents to the clinic with a 2-day history of painful urination and purulent urethral discharge. He admits to having unprotected sexual intercourse with a new partner 2 weeks ago. On examination, you note a clear discharge from the urethra. A gram stain of the discharge shows gram-negative diplococci. Which of the following is the most appropriate initial treatment for this patient's condition? So these are our options. We have oral azithromycin alone, intramuscular penicillin, oral doxycycline and intramuscular ceftriaxone, intramuscular ceftriaxone and oral azithromycin, or intramuscular ceftriaxone alone. So you will remember from the presentation that it's important to try and treat coexisting potential STDs. So we do need to treat both Neisseria gonorrhoea, which is indicated by this vignette, as well as the other common STD, which is chlamydia. Given all of this, the correct answer in this case is D. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.